Good evening. It's my great pleasure to share my experience and my view regarding plasma cell leukemia. We heard a lot about multiple myelomas. We heard about amyloidosis and poems, and this is a very unique plasma cell leukemia regarding these plasma cell disorders. My task for you will be to share what is new in 2022, and we have some news regarding this disease. This is my disclosures, and I divided my talk into 4 parts. First, I would like to share winds of change. We have something winds of change because exactly in this year, it's a beautiful paper from Roman Hayek and Thomas Jelinek. It will be published in a couple of days regarding new diagnosis, new cutoff, 2% of plasma cells regarding plasma cell leukemia and high-risk, ultra-high-risk myeloma. Later, I would like to tell you what's happened in the last 2 years in the therapy. Later, the clinical practice guidelines and some talks about future. But before this, I would like to remind you the very eminent Polish scientist, Professor Antoni Gluziński, who was born in 1856 in Poland and died in 1935. And he first in the world wrote a paper about plasma cell leukemia together with Maurycy Reichenstein. It was in 1906. He was professor here in Krakow and also later in Lemberg, in Lwów, and he finished in Warsaw. And in Warsaw he died. What's new in diagnosis? This is former diagnosis. We know it was paper published by Robert Kyle, also John Blade, and we know it was the past criteria that absolute number of plasma cells should be 2,000 or 20% total leukocytes should be plasma cells. And de novo, normally we have 60% of plasma cell leukemias. It's normal, and during progression, multiple myeloma, it's the end stage. It's about secondary plasma cell leukemia. Now it was a paper, you heard a very nice talk about CAR T cell. It's a paper published by Fernando de la Rea that cutoff is 5%. And this increased 3 times the number of patients with plasma cell leukemia. It was published according to International Myeloma Working Group publication, and it's changed prognosis. It was paper a year ago, but situation is changing every day, and we have new paper. This is a very nice paper published regarding this new criteria. It doubled its previous estimate. It was 158 new defined patients with plasma cell leukemia among more than 2,000. And as you see, it's cytopenias and adverse prognostic biomarkers were more common in this new situation. But in 2022, we have a new paper, as I told, published by Thomas Jelinek. It's accepted, and it will be published probably in another month. And we know that in new transplant ineligible multiple myeloma patients, a new study covered the new threshold about 2% as a new biomarker in plasma cell leukemia. It's like ultra-high risk multiple myeloma. This was comparison to our paper published 4 years ago regarding our study. It was published in British Journal of Hematology. We published the biggest number of plasma cell leukemia patients, and I remember a call from Roman Hayek 2 years ago that they found that 2% of circulating plasma cells, it's a new cutoff for ultra-high risk multiple myeloma, resembling behavior as a plasma cell leukemia. This was their proposal. They work on this paper many months, and it's probably will be new redefinition at the moment. I hope it will be also accepted by International Myeloma Working Group. and this is, as you see here, the very powerful predictor because you see here the circulating plasma cells is the most powerful independent prognostic factor according to others. This is the hazard ratio 3.1 according to ISS, LDH, and adult cytogenetic abnormalities. So we have a difference between multiple myeloma and primary plasma cell leukemias. The most different is that some papers tell that 70%, some papers 50%, we have translocation 11-14. And it's regarding this, cytogenetics probably will have a drug for this situation. It was many papers regarding this, and Tiedemann wrote a paper that almost 70% of patients has translocation 11-14. So this is very good, and it was paper also published from French group that people who has this translocation, the prognosis is not so bad. How we differ between primary plasma cell leukemia and multiple myeloma? We have many differences. As you see here, in primary plasma cell leukemia, it's mostly extramedullary disease. We have involvement of liver, spleen, and lymph nodes, and in multiple myeloma, of course, it's very rare. And we have also difference regarding cytopenias. Most patients with primary plasma cell leukemia has severe thrombocytopenia and anemia, and in multiple myeloma it's not so severe. Regarding M component, it's similar, and also the differences between high LDH and high beta-2 microglobulin. The pathogenesis was very elegant, published in many papers, and last paper was published from Charlotte Pavlin, and we now knew that this is still unmet need regarding therapy. How is the difference between biology? It's different because it's higher CD36 expression anchorage of plasma cell to bone marrow stroma, and in plasma cell leukemia it's much higher than in multiple myeloma. And here you see the biology, and we see that CD20 it's more common in primary plasma cell leukemia, and also it's a big difference between FISH abnormalities. Regarding FISH, it was not possible to connect today with Rafael Fonseca, but 20 years ago, exactly, Rafael Fonseca received patent regarding FISH, and he apologized for this because his telephone was not ringing, he was died. So he's very sorry about this today. Anyway, regarding mutation, we have also very high P53 regarding myeloma, and also high situation regarding translocation 11-14. It is very elegant paper published by Leo Rasche from Arkansas. He spent 5 years in this place, and he punctured many focal lesions. And this is interesting that, as you see here, in one focal lesion you can find deletion 17p, and in another it's not the same. So this is very heterogeneity in regarding this plasma cell leukemia and multiple myeloma also. Regarding staging system, it's very similar to multiple myeloma, but a couple of months ago it was a nice paper regarding R2 ISS. Also to these points, you know this staging system, you can add translocation in chromosome 1. Still, it's unmet need regarding aggressiveness of this disease, because, as you see here, many patients dying after diagnosis, and it's early diagnosis it's a problem, because this patient is going to hematology clinic in severe state, very deep thrombocytopenia, very deep anemia. and they need therapy as soon as possible. This was our paper published 4 years ago regarding real-world data about primary plasma cell leukemia and secondary plasma cell leukemia. And it was retrospective analysis covering documentation from 34 centers from 3 countries. All patients were diagnosed between 2006 and 2016. In the group of primary plasma cell leukemias, we collected 117 patients, and in secondary plasma cell leukemia, it was 101 patients. And as you see here, in this real-world data, overall survival was 23 months. The survival time doubled since last decade, so it's still unmet need, but it's much better than it was. But in secondary plasma cell leukemia, the overall survival is very poor because it's 4.2 months only. And regarding this paper, we established independent risk factors prognostic index. And it's very simple because we took age, platelets, and numbers of plasma cell in the blood. So as you see here, when patient is young, like 50 years old, platelets are quite nice, like 150, and plasma cell leukemias, plasma cell is less than 20,000. It could be survival, like over survival 46 months. And others, it's much worse situation. This is very important in clinical practice because we don't need immunophenotyping, cytogenetics. We can use simple situation like age, platelets, and number of plasma cells in the blood. So what about treatment in this situation? It's a very nice clinical trial. It's still ongoing. It's a European Myeloma Network clinical trial regarding carfilzomib and lenalidomide-based therapy as an induction, and later, of course, transplantation and consolidation and maintenance. And it's still ongoing. This is interim analysis and study. It's not because the situation is quite rare, and this is nice response in this study. And this is last paper sent me by Camila Pena from Latin America. It was presented in Los Angeles a week ago, and as you see here, median overall survival in Latin America, it's including also Mexico, it's rather poor. It's 18 months. Proteasome inhibitor therapy used as a maintenance were independent predictor factors for better overall survival in this situation. We know that it's a very important role of transplantation. It's a paper published in Hematologica, a retrospective analysis, many patients, more than 700 patients, and it was median follow-up 48 months, and overall survival was 33 months. It was a situation that patients has auto, allo, auto, and auto-allo. And this is a comparison about this. We know that probably in this situation, the best option is auto-allo to do this as soon as possible. Role of transplantation is of course very unique. The recommendation is that the best therapy on the beginning as an induction KRD or RVD, followed by autologous transplantation. Tandem transplantation also is very important in this situation. So how is the recommendation in this? The recommendation is that diagnosis should be done as soon as possible, and it's very important that intervals between treatment cycles should be as short time as possible, because sometimes patient is waiting for a bed after a cycle of chemotherapy. It not should be done, because the delay of another cycle of chemotherapy, it's not good for such patients. This is the recommendation from European Myeloma Network. Of course, first-line therapy eligible for transplantation, induction, RVD, VDD or PAT, or scheme with herpes VDD like Barlogi regimens, and when patient is eligible for allogeneic transplantation, less than 50 years old, should be referred to allogeneic transplantation. When eligible donor, when it's no donor, we should do tandem autologous transplantation. It's the best therapy. And later, consolidation, of course, maintenance is very important. This is not eligible for transplantation, first-line therapy for fit patient age less than 75 years old, free drug regimens, bortezomib, VCT, or VRD. For fragile patients, because it's also important to continuous therapy like VD or RD. In relapse therapy, because this patient is relapse very early, sometimes patient fit, we should think that it could be when it's donor eligible, we should think about allogeneic transplantation. If not fit transplant, no donor, we should think about autologous transplantation. Future algorithm, we should think that relapsing plasma cell leukemia, we should think about using daratumumab, CAR T-cell therapy, and bispecifics also. It's a future immunotherapy. This is a very nice paper regarding diagnosis. We should think about immunophenotyping on the beginning because probably 2%, as I told on the beginning, will be the cutoff regarding diagnosis, also for ultra-high-risk multiple myeloma. Measure of circulating plasma cells is a key and very important in the diagnosis of plasma cell leukemia. This is the comparison between blood morphology and flow cytometry, and you see the difference is very clear, and probably in future we should think to do immunophenotyping in these patients. What next? This is some case reports regarding venetoclax. As I told, it's very common in plasma cell leukemia, and venetoclax, it's very active. And this is a case report regarding a patient who received venetoclax after very aggressive therapy, and he has very good response on this drug. On the last, I would like to share, after contact with Martin Kaiser from UK, his very elegant study, Optimum 11 trial. This is a very nice, very intensive study. Daratumumab as an induction with cyclophosphamide, Velcade, Revlimid, and dexamethasone. Later, of course, autologous transplantation and consolidation and maintenance. And this is beautiful data. It was presented last ASH. As you see, this patient has very nice response on such therapy. Thank you very much.
Thank you very much, Artur. It came to my mind that if we have plasmacyte in peripheral blood, such situation will be better target for daratumumab because they are in peripheral blood. Although from the other hand, daratumumab is going through the barrier, am I right, from bone marrow, from peripheral blood to bone marrow. Do you think they are more sensitive to daratumumab because they are in periphery?
Probably yes, and as it was mentioned, that daratumumab, it's a game changer, absolutely, and it's very important to use this as on the beginning. I hope, I know that Polish Minister of Health has it on the table, and probably another month will be reimbursement decision regarding DRD in transplant ineligible patients and also in transplant eligible patients. We should have a daratumumab daratumumab, DVTT as a reimbursement. So daratumumab is very important in this.
Do you think there is a danger of tumoralizing syndrome when you have high level of plasmacyte in periphery after DARA?
I didn't found such data. I think no, rather not.
You remember what is the biggest white blood cell count in our patient with plasma cell myeloma?
I remember patients, it was like 50,000.
50,000.
50,000.
What, about 80% of plasmacytes?
Yeah. Yeah. It was 2 years ago, I remember such patients, yes. And he's transplanted, and it was translocation 11-14, and to be honest, it was, we think what will be the best therapy with this such patient, and we sent this patient to Gliwice, to be honest. Professor Hołowiecki is here, and this patient died after 3 months. Probably the best option for this patient will be the therapy with venetoclax, because he was translocation 11-14. It's risky, yes.
Okay, this patient of our host is open for discussion. Professor Sacha, please.
Just to clarify, regarding the recommendations of myeloma group, European myeloma group. So for patients older than 50, we start with induction therapy, then we proceed to tandem autologous transplantation, and then even in those they are in good shape, they have a good response, we should proceed to allogeneic. Right?
Less than 50 years old should go for transplantation, for allogeneic transplantation, because primarily plasma cell leukemia, it's like ultra high risk myeloma, and for sure the recommendation for European Myeloma Network is to go for allogeneic.
Yes, so that was two categories of patients, less than 50, and they should proceed immediately after induction therapy, and those for above, with the age above 50, they should proceed to tandem and then to allogeneic. Is that right?
Patients above 50 should go to tandem autologous transplantation, and it depends about response. We should think about it, but it's not, routine.
It's very risky.
It's very risky.
Procedure. Yeah, thank you.
Because I remember this patient I mentioned. He was on venetoclax as a RDTL. So this we were thinking with Dr. Pogudek very long to transfer to refer to Gliwice this patient, and this patient agreed to this risky procedure, and unfortunately after 3 months died.
Do you think that graft versus myeloma will be bigger in plasma cell leukemia?
Probably yes, I think so.
Because they are easier targets for T cells working in graft versus myeloma. Professor Hołowiecki.
Direct answer to your question.
Yes, please.
For the first time, allogeneic transplant was advised after successful DLI. So this is a good proof for immunological mechanism. And Artur, congratulations for this consequent interest in plasma cell leukemia. My question is whether we know something that can explain why these cells go to the blood. You should, maybe you did it already, look at the receptors at the cell membrane. There are, as far as I remember, at least 7 CDs which are responsible for the interaction between stem cells and the niche. From your slides, I remember CD44, it's one of the 7, but there are some rarely mentioned in the situation like CD19, 93, 56.
56, yes, CD56, yes.
As well.
This one is encouraged.
Also CD117 and 34, but 1 or 2 more.
Well, it's. I remember the CD56 is very important in this anchorage because in plasma cell leukemia it's much less than comparing to myeloma.
I very much believe that allogeneic transplantation is really a very effective treatment. But you know, such a tool should be given to well-selected patients.
That's right.
Who are well prepared. And here we have now more and more good drugs, but neither of these drugs gives a chance for cure, as for now. At the moment, we have to reduce the tumor load as much as possible and then switch to immune treatment. It is cellular treatment, and the name is allogeneic transplant. We are fascinated with CAR-Ts. It's fantastic development. It's man-made immune tool, but we have a very short time of observation. We are fascinated with this technology, but if we have it in our hand, we see how toxic is this technology. It may be these trials which base on CAR-Ts as preparation to diminish the tumor load and then after switch to transplant have a chance now to cure patients. And here I see at present the place of CAR-Ts, but cure is a little bit too complicated for this man-made immune.
I agree with your point, and I remember a presentation done by Carlos, and you remember the relapse rate after CAR-T. And also you mentioned about toxicity. I was talking with Professor Zaucha, whose patient has very severe Parkinsonism after cilta-cel. And we still, in such country like Poland, we are doing very little, too little autologous and allogeneic transplantation. Our data, I was comparing to such country like France, like UK, they are doing at the moment in transplant eligible patients like 40–50%, they are all transplanted. In this country, in Poland, we are doing 25–27%. It's still too little. We should improve in this area.
Yes, I fully agree with you, Artur, what you said now. I think we must have better induction therapy.
Yeah.
To
we will have
minimal residual disease lower before autologous transplantation, and we will have more patients with prolonged CR after autologous transplantation.
Game changer is daratumumab, and I know that the Polish Prime Minister will agree with this. I hope so. Yes.
I think so.
There is so many not well understood phenomena in multi-myeloma. For instance, as Professor Chowiecki pointed out, that there must be very strong adhesion phenomenon that patient could have, let's say, 70–80% of plasma cells among bone marrow cells, and they are not going to periphery. So it's very strict. It's nothing like that in patient with CML. Philadelphia positive cells are going outside. In leukemia, all myeloblasts after some period of time are going outside. So it's something. And another point, I talked with Artur for so many years, that patients with multi-myeloma have normal platelet count, only 30–70% have anemia, so another 60–20 have no anemia, despite the fact that they have a great percentage of multi-myeloma cell. You showed that all plasma cell leukemia, they have cytopenia.
Very severe.
Why it is? So it's so many phenomena which is
Yes.
not well understood.
So many myelomas, because I mean, CML is just, of course, this is brief. It's homogeneous disease of one major genetic change, but there are many pathways that may lead to clinically similar disease, which is called myeloma, but actually these are different disorders. And we frequently, I mean, if we don't know what we say about when we are saying 30%, whether this is 30% equally distributed between various subtypes of multiple myeloma, whether this is just 30% composed of one subtype. So this is something to keep in mind.
It's quite often a renal failure, am I right, in plasma cell myeloma? So if this could be, this could lead to anemia because of hypoerythropoietinemia. Okay, it's any other questions to our chairman? If not, ladies and gentlemen, I think we are coming to the end of this almost two days session, Congress, International Congress. All continents were represented here thanks to Artur Jurczyszyn, and I'm very glad that you came to our Jagiellonian University Medical Department, and I hope that we'll meet again, but I think that Artur will have the last word as it's privilege of the host. Thank you very much.